I am wanting to share this lecture with you on discovering and managing sarcoidosis, the mystery disease. And I call it that because they have no idea where in the world it comes from and how people get it. These are my disclosures. I do have to say that I am involved in several research studies right now regarding investigational medications for the treatment of sarcoid. Most of them are in phase 3. So what we're going to talk about today is I want to go over the history and the pathophysiology of sarcoid and the various presentations that your patients may present with. We are going to look at some pharmacologic interventions and treatments for sarcoid, and I have a few short clinical cases that we are going to discuss. So I want to get into an explanation of sarcoid and the history and how it all came about. So sarcoid was first described by Jonathan Hutchinson back in 1869. And back then it was primarily considered just a dermatological condition. And, people were presenting with rashes or bruises or some types of lesions, and they just thought it was some kind of a derm condition. But then they found that it was actually evolving into a multi-system disorder, and the majority of those cases having respiratory abnormalities. So sarcoid is basically a chronic systemic disease of unknown origin. So if you can imagine that, I mean, it was first described back in 1869, and here we are in 2025, and they still do not know the origin of this disease, which is pretty frustrating because I will share with you all that I am a sarcoid patient. I have cardiac sarcoid. So the pulmonary manifestation of sarcoid presents with bilateral hilar lymphadenopathy with pulmonary infiltrates. You can have ocular lesions, skin lesions. And the diagnosis, when it's pretty much, they do a chest x-ray and they look at the chest x-ray. I'm going to show you an example of that, but there's some pretty characteristic features. And then they go through and they do a histopathology of epithelioid cells, which are really granulomas. And then they exclude everything else. Okay, so they look at what other diseases are there out there that can produce this granulomatous inflammation, and let's look at all those and rule those out. So it's one of these things, almost like ALS, where they rule out all other types of neuromuscular diseases. And if it's not any of those, then it's ALS. So they will rule out any other disease states that can cause granulomas and inflammation. And once they've ruled all that out, they make a determination that, yep, you've got sarcoid. So in 1869, Hutchinson, he was a pretty prominent disease doctor of the skin in London. And he had a visitor at his home, actually, who was a 58-year-old wharf worker, which means he worked on the docks. He was working on a fishing boat. And he was complaining to Dr. Hutchinson that he had these purple symmetrical skin plaques on his legs and his hands. So Dr. Hutchinson first described these lesions, and they weren't painful for him. They really didn't affect his life per se. He just didn't like the way that he looked. So he just kind of said, well, I think this is related to your gout. Next, he treated another patient by the name of Lady Mortimer. And Lady Mortimer was a woman of high standing back then. And she also presented to Dr. Hutchinson with these raised lesions, and they were on her face and her forearms. And they proceeded to get worse over the next 6 months. So he was trying to treat her, figure out where this was all coming from, and he couldn't really attribute them to any other disease state. So he labeled her condition as Mortimer's malady. There was another French dermatologist. His name was Ernest Beisner, and he coined the term lupus pernio to describe a patient that had purple swelling of his nose, ears, and fingers back in 1889. And I do have an image of lupus pernio to show you. In 1899, Caesar Beck was a Norwegian dermatologist, and he presented a patient case to the Medical Society of Christiania. And this patient had a benign sarcoid of the skin. So he emphasized that there was a lot of similarities between the sarcoid of the skin to Mortimer's malady. So Beck coined the term sarcoid because the lesions look like sarcomas. And he was also the first physician to describe the granulomatous histology of sarcoidosis. So before his death, he published a series of 24 cases of benign miliary lupoids. Some showed involvement of the lungs, conjunctiva, which, is inflammation of the eye. He found lesions in bone, lymph nodes, spleen, nasal membranes. So all this multi-organ nature of sarcoid began to emerge. So there is a lot of subacute variants of sarcoid. There is lupus pernio, which I already talked about. There's Herfurt syndrome and Lofgren syndrome. This is an example of the lupus pernio. So you can see on this patient, she not only has lesions like on the side of her face, but she's got it's around the whole circumference of her nares, and it's around her mouth as well. And if you look closely at her, especially her left eye, the one that would be facing us, she's got some inflammation above her eyelid and below her eyelid. So Herfurt syndrome is a subacute variant of sarcoid, and it's characterized by enlargement of the parotid and salivary glands. There is some facial nerve paralysis. There's anterior uveitis, and that's an inflammation of the iris and the ciliary body that's in the front of your eye. So this patient here, you can see she's got the paralysis over on the left side of her face. And this is what you would typically see when you have the eye involvement. It almost looks like a case of pink eye. But if you look around the upper and lower eyelid, there's some inflammation, some scaling, and almost a yellowish tone of the skin. Lofgren syndrome was first described in 1946 by Sven Lofgren. He was a Swedish pulmonologist, and he said that this is a rare phenotype of sarcoidosis. The lungs are the most common organ affected, with secondarily being the skin. He said now cutaneous manifestations are seen in about 33% of the cases, and having sarcoid on your skin is most often the first clinical sign of the disease. So a lot of patients will present with, they think they have psoriasis or something else going on with their skin, and they go to a dermatologist and get a bunch of creams and this and that, and nothing's really, addressing the situation or making it any better. Those patients, if they're not getting any relief, they should actually go and be seen by, usually it's like rheumatology treats a lot of sarcoid, or go to a specified sarcoid clinic and have that investigated a little bit further. So Lofgren syndrome usually presents acutely. It usually hits patients that are younger, and they have an onset. It's when it says urethma nodosum. That's how that's pronounced. and I'm going to show you what that looks like. And then you have bilateral hilar lymphadenopathy. And they call that on the x-ray when a pulmonologist or a radiologist is looking at Lofgren syndrome and they see this unusual, or it's really it's a typical chest film for a sarcoid patient. They say it has the pawnbroker side, and I'm going to show you where that came from. They also present with fever, they have migratory polyarthritis, and without granulomatous skin involvement. So this particular presentation of sarcoid doesn't have that plaquey skin involvement. So this is the nodosum. So it almost looks like bruising of the skin, but it's red in nature and it's a little bit warm to touch. So it shows up all over it can show up anywhere, usually front of the legs, back of the legs. It can be on a patient's arms, on their back. But this is what you're looking at. It's just really blotchy, warm red spots. And this is what they're looking at in a chest film when they say the pawnbroker sign. So back in the day, way back in the 1800s, when somebody owned a pawn shop, that is the symbol that they would hang outside of their store. I'd like to look at the history of that and figure out why those three balls would be a sign of a pawnbroker. I'm sure there's a reason for everything. But if you look at the chest film and you look at the hilar areas of the lungs, you can see you have that patchy opacity there. And that is typical of what you would see in a sarcoid patient's chest x-ray. This is just another couple images of the same exact thing. So you can see the patient on the left side of the screen has a bit more patchy infiltrates, where the patient on the right looks like they're in more earlier stages, but you can still see it. It's typically in that same area on both sides. So how do we diagnose sarcoid? You don't. You don't, there's no real definitive testing that exists that you can't draw labs or do anything and say, yep, you have sarcoid. You have to figure out what it isn't. So like I said before, any other diseases that can cause the formation of granulomas. Tuberculosis is a big one. You have to rule those diseases out first. And it's really a presumptive diagnosis. So they see that x-ray and it's pretty stereotypical, so they can say with relative confidence that a patient probably has pulmonary sarcoid disease. So if it deviates from, its classic course, or if it, fails to resolve, this just isn't going away, and which was in my case, I had cardiac inflammation, and they did not know. They attributed it to COVID, because I did have COVID, and I had cardiac inflammation that just wasn't going away, and they were treating me and trying to, see what they could do to make it better or figure it out, and they couldn't. So it just wasn't resolving. So then you have to get more into histological diagnoses, and perhaps, start doing a biopsy. If a provider is going to consider doing a biopsy on a patient with sarcoid, the lesions aren't usually a good choice, because you actually need a sample of the granuloma. They have to confirm that you have granulomas. Lymph nodes are usually chosen if they're not, readily accessible superficially, like if they can't just go in and do a needle biopsy of a lymph node. They have to get a little bit more invasive, which is exactly what they did with me. I ended up having a flexible bronchoscopy with an EBUS. So they saw an enlarged lymph node in my mediastinum. So I had to have a bronch, and they went through and did a needle biopsy. And in fact, that particular lymph node was positive for granulomas. So I finally got my diagnosis after 3.5 years. So this is what they're looking for in the histology of sarcoid. You want to, there is epithelial cells that are surrounded by lymphocytes and fibroblast, but they are devoid of the cavitation. So if you look over on the right, you see that big purple spot there. That is actually a granuloma. Sometimes for the case of certain types of sarcoid, when they're trying to biopsy an organ, whether it be your heart or your liver or your spleen or something else, it's almost like shooting a dart at a specific spot in a football field. You really can't guarantee, they can try to assume that they're in the right area to try to get that specimen, but it doesn't always work. It's not always positive. So sometimes it's just a shot in the dark to try to get that one little granuloma in that large area. So this isn't the best slide ever, but sarcoid, it can affect so many different parts of your body. And the sad thing is it never really goes away. It can go into remission, but it can come back in a totally different area. So some of the affected areas, obviously, we have lungs, skin, lymph nodes. That's supposed to be joints. Sorry for my misspelling. You can get sarcoid in your eyes, in your heart, in your nervous system, in your brain, in your muscles, in your kidney. It can just go all over the place. It's highly unfortunate, isn't it? I mean, this is a terrible disease. So who is at the greatest risk for development of sarcoid? Primarily Caucasian females. It can happen in lesser frequency, but it does happen in African American men and women. People that have an existing autoimmune disorder. So if you have arthritis or lupus or thyroid disease, it seems like anybody that has any autoimmune disorder is at a greater risk. I will tell you that I ended up having to leave my hospital and go to Cleveland Clinic a few times because they were trying to figure out, not only what I had, but how I got it. And my family all has a history of thyroid disease. My sister has also ulcerative colitis and thyroid disease. And they said, I just happened to draw the short straw and end up with sarcoid. So it can happen to anybody at any time. And you can either have multiple symptoms or you could have sarcoid and have absolutely no symptoms. There is no rhyme or reason, despite research, and there is a lot of research when it comes to sarcoid. There's a lot of communities and money being thrown at this, and they can't figure out why this is. So some of the signs and symptoms, if you do have them, or a family member, or you're treating a patient, they could present with maybe some of the skin lesions like I talked about, and maybe one or more of these. They can have night sweats. If you have heart involvement, you can have lightheadedness, cardiac dysrhythmias, usually caused by complete heart block. Shortness of breath, coughing, weight loss. You can have any of these raised pink, purple, the painful nodules under the skin, or you can have skin lesions that are not painful at all. You could have a low-grade fever that is, 99, 100, that just doesn't go away. You maybe take a Motrin, it goes away for a little bit and then comes back, but you have no other symptoms like cold or flu or anything else, just a weird fever. You can have red, painful, dry eyes and problems with your vision, enlarged, painful chest, lymph nodes. It doesn't even have to be in your chest, your lymph nodes in your neck or any other area, but primarily they're in the chest, but they can be in other areas as well. An enlarged spleen and or liver, and then chronic fatigue symptoms. Oh, thank you. I see Valerie says it's an awful disease. Yeah, I have an AICD. My story, that's a whole nother talk I'll do one day for you guys. So these are some of the physical manifestations that you will see. The cutaneous sarcoid. Now, if you look at that, to me, that just looks like a really terrible case of psoriasis on this patient. I don't know that I would have really classified that as a sarcoid, but it is. It's cutaneous sarcoid. The poor patient on the other side, just for privacy, we just blacked out her eyes, so she has eyeballs in there. We just covered them up. But she had a very unusual variant of sarcoid. This is also cutaneous sarcoid, but she did get it on the end of her nose. You can get oral sarcoid. So this patient, as you can see, there's some sarcoid lesions with some blistering on the inside of his lower lip. And then this patient over on the right-hand side has sarcoid on the soft palate of the mouth. So this is an example of pulmonary sarcoid. So again, you see in the chest x-ray, you see the typical pawnbroker sign. So you have in the, mid-hilar region of the lungs where you have the fluffy infiltrates. And then when you look at some more severe cases of sarcoid on a chest CT, you see a lot of pulmonary scarring and nodules. And some patients get this really severely. They don't respond to treatments, and the only treatment for it is lung transplantation, sadly. So this is example of ocular sarcoid. So you can see these patients were diagnosed, they had gone to ophthalmology clinic, and you see all the granulomas in the eye. So that's what they're seeing when they're examining these patients closely under microscopic examination. And the one on the right, you can see that they just have all the red irritating tissue around the eye that looks like broken blood vessels, or almost like pink eye. But the difference with pink eye is pink eye, you have a lot of that pussy, sleepy substance, and your eye is usually very watery, where this tends to be a little bit more painful and dry. There is a dry eye involved in this, and then it starts to involve the upper and lower eyelids. So if you actually lift it up, the patient's eyelid, or even if it was yourself, you've lifted it up, you're going to see that irritation under the lid. So how do they diagnose this? So if we're going to start throwing things out, some of the tests that a patient can anticipate experiencing is a complete medical history and a full examination. Obviously, chest x-ray. If you have pulmonary involvement, they can expect to go through some pulmonary function testing, not only for flows and volumes, but they would want to get a DLCO for diffusion if it is in fact producing some scarring within the lungs. They can experience a bronchoscopy like I did, complete eye exam. The blood testing, what they usually look for is sarcoid can cause elevated levels of vitamin D, and they will also look at angiotensin converting factor. CAT scans, gallium scans, PET scans is a big one, especially when they're looking for active disease. I have cardiac PET scans. and they look for the inflammatory cells to light up once you get the radioactive isotopes that they give us when you have a PET scan. They do EKGs for cardiac sarcoid because it causes rhythm disturbances. Usually it starts out with maybe a bundle branch block and some, varying heart rhythms. Sadly, I was in complete heart block, which was a little frightening. And most often, if you look it up, that's the worst thing I did is when I found out I had cardiac sarcoid was, you go to Dr. Google and you start looking things up as far as prognosis. And cardiac sarcoid is usually diagnosed post-mortem. So they find it on autopsy that people weren't even aware of the fact that they had it, and they went into a terrible dysrhythmic episode and just died of sudden cardiac death. And they can do biopsies, like I said, if they can get a good spot, if they're sure, if they see a good lymph node that they can grab. It might not be that easy from other areas, such as the skin and other organs. So full disclosure here, Dr. Ouellette is a big researcher when it comes to sarcoid. We have a sarcoid clinic at our hospital, and he participated in this paper where they were doing a little investigational thing, and they found out that angiotensin converting enzyme levels is is really an important test to draw when it comes to sarcoid. So it says that it's suggested that the degree of elevation correlates with disease activity. So as they're going through, the rule out stage of other things, they can draw ACE levels in a patient. And if that is elevated, they can start looking towards a clinical diagnosis of sarcoid. So the most important question for this is, should I treat a patient? And if I do, how do we treat this disease? We don't know very much about it. So should I treat it? Should I put a patient on a big regimen of medications? Or should we sit and wait and see what happens? Some cases of sarcoid resolve on their own in patients and just goes away and doesn't come back. Others don't respond to treatment at all. So when they're deciding to treat a patient at most sarcoid clinics, they put them in these classifications. Either the patient is in absolutely no danger. Um, they've done a chest X-ray, and that's how we diagnose this. If it looks like a duck and acts like a duck and quacks like a duck, it probably is a duck. So if they've done that chest X-ray, they see that pawnbroker sign, but the patient just has a real mild cough, for the most part, they feel okay, they're in no danger. Then you have the no danger with impaired quality of life. So these patients are a little bit sicker. They may complain of dyspnea, cough, having some mild skin involvement. They can have some joint involvement and joint soreness. But overall, they have a stable pulmonary function test and a chest X-ray. Danger is when you have progressing respiratory symptoms, deteriorating PFTs and chest X-rays. There is ocular, neurologic, or cardiac involvement. There can be some disfiguring skin, as you saw with that one patient that has terrible nose involvement there, and hypercalcemia. So these are the treatments. This was published in the European Respiratory Journal back in 2021. This is pretty much the gold standards for treatment. The number one medication that you give a patient with sarcoid is glucocorticosteroid, or You know what? Let's just call it prednisone because I can't pronounce it today. So any kind of a steroid. So steroid medications, usually it's 20 milligrams once a day, and then they will do the taper. I had a very aggressive inflammatory effect, so I had to take 40 milligrams of prednisone for 3 years. It was tons of fun, let me tell you, people. So a lot of prednisone, methotrexate. You have a whole list of medications in here that will cause you to be immunosuppressed. So one of the things about sarcoid is it makes your immune system go cattywampus. So this is just an overactive immune reaction that your body has to what? We don't know to what, but your immune system just goes crazy, and then you have all these clinical manifestations that can appear all over your body. So how are we going to treat that? Well, we're going to do the prednisone for the inflammation. You have to get the inflammation down. You need to correct the or get rid of the granulomas, because those are the things that cause permanent scarring and damage to your tissues and your organs. So most importantly, get that inflammation down, and then you have to quiet down the immune system by using one of these medications. It might be one, two, it might be a combination of things. I had to take a bunch of cardiac medications, metoprolol and lisinopril and all these fun things. I also did prednisone. I injected myself with methotrexate once a week. And then I had to take Hadlima, and I had IVs. It's just crazy. And they will treat you, and then they test you. You'll get more imaging, more scans. They want to see the disease go into remission. They want to see resolution in the inflammation, or the an improvement in the skin, or the lungs. They want to make sure that the inflammation is gone, and then they want to keep you suppressed to keep the disease at bay. Once they're sure that you're in remission, depending upon how the patient's doing, some doctors will withdraw all medications and just see how it goes. Others will opt to keep a patient on a low dose of prednisone or some other immunosuppressant drug like Hadlima or Humira, drugs of that nature. It just depends on the patient and their response. And some patients, sadly, don't respond to any of these things. They try a treatment plan, and they try something else, and that's not working, and try something else. And ultimately, patients are left with heart transplantation or lung transplant. And yeah, it took 3 years to diagnose me, Terry. That is correct. Because I was a healthy, active person that just went to poop overnight, I'll tell you. But I'm doing great now, though. I will tell you, I have a great team. So I want to go over a couple of cases with you based on what we said about, are these patients at risk? Are they in danger? Are they no danger? So this particular case was a 30-year-old Black man. He was admitted to hospital. He had dyspnea, cough, a right upper lobe infiltrate. Symptoms were present for several weeks, and he did report a fever at home. So some of these things, since I've been talking to you, you should be going ding, ding, ding. He was employed by the post office, and he was a National Guard reservist. Recently, he returned from desert warfare training in the Mojave. He is a non-smoker. He is negative for HIV. So he presented with a chest x-ray and a CT that demonstrated that bilateral hilar adenopathy, and I have to move the chat box here over, and right upper lobe airspace disease. So on physical exam, his eyes and skin look great. He had a normal calcium. They did do a bronchoscopy on him. Okay, so he had a normal airway exam. He did EBUS biopsies. There was non-cavitating granulomas, but no organisms identified on the pathologic section. So he had some granulomas, but nothing really showed up in the pathology reports. So what should we do to this guy? Should we just go ahead and start him on medication? Should we start him on methotrexate? But, I said the drug of choice is prednisone, but bam, 40 milligrams daily. Should we get a quantiferin gold test, fungal serology, look at some cocci serology to reference in the lab? Or should we order a lymphocyte transformation test? What's probably the best thing here for this particular patient? The correct answer is they're going to go ahead and look at the quantiferin gold test and fungal serology, because where did he say he went? He was working in the Mojave Desert. So really, to start off the jump with methotrexate, that's probably not something that we would start with. They would probably start him with prednisone, but usually the starter dose is 20 milligrams, not 40. So the treatments have no side effects and not really proven to change outcomes. You're just treating the condition. So, like I told you, sarcoid is a diagnosis of exclusion. So you want to rule out all these other things. You want to exclude that he has TB or any other histology or cocci, no neoplasms, environmental or occupational exposures, and then look at any autoimmune or other inflammatory conditions and drugs. So for this guy, he's got a little bit of a history. They're going to watch him, but they're going to rule out these other things first before they end up with a sarcoid diagnosis. So this is the treatment. Again, this is from the Europe. Oops, sorry. Oop, let me go back to that. So these are all available online from the European Respiratory Journal, and this is a pathway for treatment, and it kind of guides where you're going to be at with treating these patients. So when you've determined that they do have pulmonary sarcoid and they're low risk, you're going to observe them and just look at the possibility of giving them, there it is, the glucocorticoids. That was the word I was trying to say and failing. All right, then if they're at intermediate risk, but they have impaired quality of life, that's when you want to look at those secondary and third options, infliximab and methotrexate. And then you're going to go across, and if they have, good clinical response, then you can start tapering the steroids. So if they're responding from steroids, you're getting that inflammation down. You want to keep them on these other drugs to keep the immunosuppression active, but you can get away from those evil steroids. Boop. So here's another patient case. 28-year-old woman she's had a cough for 2 months and skin rash for a week, fevers, fatigue, chest pain. Her serum chemistries are normal, to include ionized calciums, PFTs, normal. So she has non-caseating granulomas were found, and infectious serologies were negative. So this is her exam. So if you look at her legs and her chest x-ray, it looks like she has Lofgren's syndrome, doesn't it? So she's got that bruising and that typical chest x-ray. So if you look at her diagnosis here, so what do you think her diagnosis is, and what is her danger level? Is she no danger? Is she no danger with impaired quality of life? Or is she in grave danger? And then what would our treatment choice be? So this particular lady, she in fact has impaired quality of life. So then we would start her on that prednisone of 20 milligrams for several weeks and then monitor her course as an initial therapy. If she was not responding, then they would go in and add those secondary medications. So again, this is the immunosuppressive therapy for pulmonary sarcoid. So no danger with impaired quality of life. So we would go down that middle road because she isn't in no danger. She does have the effect of, her quality of life being bothered, but she hasn't reached that danger phase. So this is a 40-year-old man with a biopsy confirmed sarcoidosis 5 years ago. He's presenting with peripheral edema and dyspnea. He had 6 months of prednisone. He's now got an elevated BNP. His calcium level is up. His chest X-ray. Here we go. We got curly B lines and small bilateral effusions, adenopathy, upper lobe mild bronchiectasis, airspace. His echo is 25%. So that left ventricular ejection fraction is down to 25%. It's critically low for this guy. And his cardiac PET scan is positive for sarcoid-like inflammatory changes. So, I mean, what do y'all think from this point? I think this guy sounds like he's more in danger, right? So here we go with this. So obviously he's not in no danger. He's got more than impaired quality of life. He's got critically low ejection fraction. So where should we go on the pathway with him? He is in fact danger. So because it seems he definitely went from pulmonary involvement to now include cardiac sarcoid. So absolutely placement of an AICD so he doesn't, he's protected from dangerous heart dysrhythmias. Prednisone 40 milligrams daily, and then consider combining that with methotrexate or one of the other immunosuppressant drugs. So here you go with this. This is for cardiac sarcoid, so immunosuppressive therapy for cardiac patients. And this is pretty much what they follow. Definitely pacemaker, implanted defibrillator, the steroids with methotrexate. And then depending on if they respond or not, takes you down the pathway and the course for treatment. So this patient presented with lupus pernio, 35-year-old woman with a facial rash. She is previously confirmed sarcoid. She failed topical steroids, oral prednisone, and methotrexate. She has a normal pulmonary function test, echo, and her ionized calcium. So I would venture to say that would impair my quality of life, having my face like that, the poor thing. So what are we going to do for her? Of course. Okay, so she's in no real danger, but she does have an impaired quality of life. So then we're going to get her on the skin sarcoid pathway with those treatments. So it may include hydroxychloroquine. And if you remember, boy, that was a drug of questionable uses back in COVID. But there is all kinds of, different things that we can try. And if one treatment does not work for a patient, there's other combinations that we can go up the scales. So for managing sarcoid, you have to treat for definite indications. You want to watch for adverse effects because some of these patients do. I had an allergic reactions to one of my medications that they gave me. So then they have to stop that therapy, reassess, and to figure out where else you can go on that pathway. it's very important to assess patient danger. Are these patients at high risk? Because if I'm going to tell you right now, if you are suspecting that somebody may have cardiac sarcoid, I mean, that's really a life or death thing. They could be, working out at the gym or just at work or driving their car and have a cardiac event and just pass away. It's really imperative that they get diagnosed and then protected. So these algorithms with the recommended agents, I mean, this is based on research. Again, it's all treatment, trying to get the disease into remission. There is no cure. Can it spontaneously go back to sleep and stay away for a while? Yes. Can it come back? Yes. Do we know why? No. So invite your friends to the party. My Sarcoid team or any Sarcoid clinic has multiple specialists that are involved. And it's everybody. It's um, pulmonary, infectious disease. I have cardiologist, electrophysiologist, neurologist. It's a big team of doctors that get together to talk about all of the sarcoid patients, what is their manifestation, making sure that they're filling all the holes in the Swiss cheese and that all the patients are covered and they're checking, consistently. So you have to go back and be seen in the clinic, pretty often initially, and then usually they recommend once a year after, but the patients are followed very, very closely to make sure, and they're also told that, hey, if something new pops up, something unusual, if we're downloading your AICD every 3 months and we see some disturbing rhythm changes in the background, then they know to check you to see if the disease is active again. So they keep close eye on you. They're going to use all the recommended algorithms for each affected organ with the recommended agents. And you have to be open to novel mechanisms of disease in the future. Like I said, there is a lot of research out there. There's a lot of money, drugs on the horizon, but again, it's all just different forms of treatment that we hope will be more successful for sarcoid patients in the future. But who knows where it leads. We just take forever to get these things approved. But being involved in the medication trials, again, I am one of the researchers. I am not part of the study trials. I can't be, because when you have cardiac sarcoid, there's nothing really measurable for a cardiac patient. For pulmonary, we do the pulmonary function testing, the diffusion studies, and 6-minute walk tests and other things. There's quantitative measures involved there, where if you have sarcoid, in your brain or your eye or your heart, there's not really a quantitative measure that can be used. But hopefully, in the future, we will find a cure or at least discover why sarcoid awakens in us. It's all in there. It's all in us right now, being sleepy, but what is it that wakes it up? So this is, if you can look, you're going to see a man. You see the man with the glasses, and then directly behind him, there's a physician with white hair and a mustache. That is Dan Ouellette, who was in Lausanne, Switzerland back in April 24th, 2017, where he participated in the International Sarcoidosis Guideline Panel and was instrumental in developing these treatment pathways for sarcoid patients. So that's my shameless plug for my medical director. See, there he is. That's Dan. So with that, I want to thank you all so very much. for listening to me blab about sarcoid.